field trip to the Netherlands to talk about what the Dutch healthcare system looks like. You know, as we get closer to winning Medicare for all, which has already been won in the court of public opinion, of course, but we're seeing new arguments crop up explicitly that, you know, Medicare for all is actually just one of many ways that we can guarantee universal coverage to everyone, and that dismantling our for-profit employer-based health insurance isn't, you know, actually necessary to ensuring, you know, health insurance equality. The position that Healthcare Now takes, of course, is that this is not true. A publicly funded and administered system is the only way to equitably deliver healthcare. But proponents of, you know, the existing corporate healthcare system will say, well, you know, look at a system like the Netherlands, which is run by private insurance companies. Vox earlier this year published an article about the Netherlands healthcare system titled, you know, the Netherlands has universal health insurance and it's all private. And I felt that description was glossing over some important differences, if not just outright wrong. Ben, do you want to introduce our guest?
Yes, and I can't wait until we can actually take a field trip to the Netherlands. I mean, hopefully sometime in the next year that will be possible again.
This is the best you're getting for now.
We are so grateful to have as our guest here a Professor Kika Ookma. I hope I pronounced that okay.
Pretty good.
And please just tell us a little bit about, I mean, first of all, how did you end up getting into studying healthcare systems and health policy? And tell us a little bit about your career and the type of work you've done.
Well, thank you. Thank you for having me. And I'm really happy that there's sort of some organization in the US that shows interest in anything across the borders. That the rest of the world seemed to disappeared in the last decade, and it's still maybe useful for us. As to my own career, I've been, I was a student in economics, macroeconomics. I didn't quite know what to do. I was hanging around the university for years, and then I stepped and became over to government. I became a government employee for 2.5 decades. I worked with the Treasury, with the Foreign Affairs Department, with the Commerce Department, and I sort of been zigzagging around in different government agencies. I worked for the World Bank for a couple of years in the early 80s, and a monetary fund, went back to Europe. So I've been going around in public organizations for 2.5 decades. And then my last job in Holland, the last 10 years, I accidentally, someone had referred to me that position. I was hired by the health department. It wasn't because of my background. I had no medical background. I had no knowledge whatsoever about healthcare. So I had to read up, I had to catch up a lot the first couple of years. And healthcare, yeah, I really realized it's one of the most interesting, one of the most complicating, challenging parts of public life, because more than any other department, defense or education or social matters, it has both the issues themselves, but the medical issues are fraught with ethical issues, media expenditure, complicated stuff. It also has many more organized and sometimes very well organized stakeholders that all can thwart and block government proposals. And it is a matter of life and death. You read the headlines every day. So it's exciting to work in healthcare. And I was hired at the time to be the executive secretary of the committee to implement the latest round of reforms proposed in the late 1980s. You can see that I'm already a little bit older now. So we were struggling then how to that report that was talking about more competition, risk-bearing sick funds, level playing field between the private and public industry. So all the issues we're talking now, you were just mentioned, how to translate that into legislation. And we made an enormous schedule of all the legislative steps we needed to do. And in the first couple of years, things seemed to be doing fine. The report was discussed. It was an enormous controversial report, but in the end, there was enough political support. We started implementing 2 or 3 years later. All of a sudden, turned out all the seemingly appeased stakeholders didn't like it so much. Opposition resurfaced, political support eroded, and it was completely blocked. In 1991, I remember I visited Washington with 2 of my colleagues, and we were invited to the White House to talk to the health czar of Clinton, Magaziner, I think, yeah. And we were commiserating how both the Clinton plans had tanked and at the same time the Dutch plans had tanked for different reasons. But that was, so in any case, I worked my way through all those different fields. And after 10 years working at the health department, I decided I might as well write a PhD, because Holland's one of the few countries where you don't have to go back to school for a PhD. You just have to write, when you've graduated, you just have to write a book. You find a friendly professor, write a book. So I wrote my book, did my PhD, and that triggered an academic career I hadn't planned either. And I was invited by universities in Canada, at UBC in Vancouver, at Queen's University, McGill later. And in the United States, I then, another 10 years later, I met my now American husband. And so I started a new life in this country. I'm now also American citizen in both continents. And I have been teaching at here in Cornell Weill and at NYU and Columbia, different places, always with sort of international perspective, comparing what is going on in different countries. I always find it very exciting to look at other things but yourself. It helps to better understand what's happening in your own country.
I suppose you're qualified to talk about the Dutch healthcare system with us and how it compares to the US.
Yeah. And I agree with that. I'm married to a Danish man, and I lived in Copenhagen for 3 years, and I experienced a true socialized health insurance system, and that definitely put my own healthcare system in perspective. So I think maybe we should just jump right into the Dutch system. Can you tell us a little bit about the major reforms that happened in the Dutch healthcare system that sort of ended where we are today, and what it sort of looks like, before? I know that there was a major reform in 2006. If you could just sort of like lay out what had precipitated that reform and what it looks like now.
Well, let's briefly summarize what is happening now, currently. Currently, 100% of the population is under the 100% of the legal residents, I should hasten to add, are obliged to sign up with a health insurer of her or his own choice. The payment, 90% of the payment, is channeled through the tax system. So the government, the employer withholds earmarked taxes, and it is channeled through the health insurers, and less than 10% is paid by the insured directly to the insurance company. So you can choose your insurance, you have to pay about €100, $120 per month, and then everyone has the same basic package of entitlements and the same access to healthcare. And there's a little bit of, in the margin, additional supplemental insurance you can take for things that are not really covered, like dental care for adults and some eyewear. I mean, that's not very important. And the number of people who've taken that additional insurance has gone down because people think it's a lot of money, it's not worth it. But anyway, so it sounds very simple. The part whether the insurers who are managing that insurance, whether they are private or public, that's a very interesting question, because that question has never been answered. And it's an interesting one because when the government introduced the plan in 2006, the then coalition government, presented the plan as a private insurance. But then some people at the health department, and I worked at the health department then, said, Minister, you can't do that, because the Treaty of Europe, the European Union, the Council of Europe, the International Labour Organization, all those organizations, they require that member states cover their member populations at least for 2/3 with social health insurance, not private health insurance. So you can't do that. We are not going to step out the EU if you, the minister said, but you know what, we'll just call it social insurance. And we went on with that. Now the problem is that it's not just semantic. The social insurance are completely different in a different legislative regime as private insurance. If it's social insurance, governments can interfere, can do stuff, but you cannot at the same time have competition and consumer choice and free negotiation over prices and quantities between insurers and hospitals, say. If it's private, you can choose to have a private system, but then you, as a government, it's part of competition law. And governments cannot interfere in the price setting of private health insurance or in prescribing what they're doing, as we're doing now. So that's, and the question, the only authority who can judge on that question is the European Court of Justice. And there has never been a case. As soon as there will be a citizen or organization going to Luxembourg to the court, if I'd lived in Europe, I would do that perhaps. Then the court would have to decide, but it hasn't decided. But anyway, so it's a bit, it quacks like a duck and it swims like a swan. It's not quite private. That's the insurance, about 40 independent insurance, but actually they're all in the hands of 4 private big insurance conglomerates that are private profit maker. So is it private? Is it public? No one knows.
Right. And when I first learned about the Dutch health insurance system, I saw that the premiums were only like €100 or just over €100. Yeah. And that like the max deductible is like €500. And I was like, how did the Dutch system get their premiums down? So like what incredible cost control they do. And of course, the reason that it's so low is because it's massively subsidized by the public sector, which is sort of funded rather by the public sector.
What's your words here? I mean, there are 2 things. That's the fact that you channel money to the tax system is not necessarily subsidization. Mm-hmm. I think there's a difference there. I mean, earmark taxes is like you're paying a contribution, but you channel it. It's a separate account. It's channeled to insurance. So it's more the income-related contributions, as in all the other social insurance system, like our Medicare in the US, for example, our Social Security. Your employer withholds taxes, and it's channeled through the tax system. That doesn't make it direct. You can't call it tax subsidy.
Right. So rather than subsidize, it's really funded.
But you're right in noting that the biggest share of all the payments in Holland go through that income-related premium system. So it's not as if all of a sudden we pay flat rate premiums, and it's $100 or $120 a month seem trivial in the eyes of the US. But as I'll say a little bit later, it has caused major problems in Holland. I'll tell you about it. I want to also come back to one of your remarks about socialized healthcare in Europe. I think even in Scandinavia, I think that's a real misnomer. It's misleading, and it's a false label. You can say we have largely across Europe socialized the health financing, but we have not largely socialized healthcare, the provision. Most countries have either a mix of public and private hospitals or mostly independent hospitals with mostly not-for-profit independent hospitals. Mm-hmm. But there is public financing. So that's important because it gives a different meaning to the notion of socialized medicine. And I think, in fact, there are about 2 countries in the whole world that really have socialized medicine, and that's Cuba and North Korea. All the other nations in the world have this mix of, so that's why that label is not helpful.
Oh, yeah, we have the same thing here where, especially dating back to the 1950s when, not universal healthcare was attacked as socialist. It was mislabeled as socialized medicine as a way
even
of
in the 1930s. Same in the 1930s. Roosevelt, he also was the same debate. So it's you have to be very critical about it. I mean, it always drives me nuts when my friends talk about socialized medicine. I say, you don't know what you're talking about. But it's more the annoyance that it has become so effective as a weapon in the policy debate, and we have to be careful about that, I think.
Mm-hmm. So to add additional confusion and intrigue, so I think part of the problem that we in the US who only have familiarity with the US system have in wrapping our heads around a Dutch-like system is we don't have many systems or provisions in the United States where there is a private entity who is delivering it, or at least a pseudo-private entity who's delivering the product or the service, but it's mostly paid for through the tax system.
Wait a minute.
Yes.
You're wrong there.
Okay.
If you could briefly describe the American system as it's complicated, it's very fragmented.
Well, you're true. There is a lot of public financing of the American system.
It's fragmented. I mean, you have the Medicare, over 50% of the population. It's social health insurance. Medicaid, it's tax financed, but it's provided often by private hospitals. Local, state authorities negotiate with hospitals and clinics and nursing homes sometimes. Then you have the Veterans Administration, America's socialized medicine. public hospitals, public financed, and Indian services or prison service. I mean, there's a lot of population, little smaller groups. And then we have, after the Obamacare, the ACA, the private insurance, the group insurance we all have through our employment-based insurances that used to be real private group practices often, but they have been transformed in something that has been looking a little bit more like social insurance. The mandate to insure, that fell through, but that idea or the prohibition to risk rate premiums, to accept everyone, all those elements are the fundamentals of social insurance. So our private insurance has already moved quite a bit towards social insurance. So before throwing it overboard, because it's sort of profit making, I think maybe we have to look at that more carefully. The insurances in Europe also started as employment-based arrangements.
So let me ask you some other questions about the Dutch insurance systems, because I also wonder, just as this term private is kind of a loaded term and it doesn't quite capture the complexity of what's going on, even the term insurer is a little complicated, right? I think what we would consider an insurer here would not be considered an insurer in the Dutch system. So what happens in the Dutch system if someone does not pay their premium, for example, if they default or fail to pay?
That's good. There are two different things that happened after 2006. The one thing, the transition was fairly easy from this dual system for 40% of the population with private health insurance, 60% plus with social health insurance, and those two merged into this universal mandate to take out insurance. And that transition, remarkably, was fairly noiseless. It went well. And the reason it was sort of successful, it seemed at first, was that all the major actors in healthcare in Holland had anticipated that legislation. So insurers, the private insurers had already merged with the sick funds, even legally, not quite, but they had already done that. The number of insurers agency, whether public or private, had been going down dramatically. Likewise, in the provision of healthcare, hospitals and others started also to think, oops, I have all those strong insurance conglomerates in front of me, and they started to merge. So we developed hospital systems that often resulted in regional monopolies or oligopolies with only few hospitals in a region and one or two insurers. So that's one of the reasons why cost control was so ineffective. It's economics 101. You have a regional monopoly, bilateral monopoly, demand and supply is monopoly. So prices will go up.
Same thing
happens.
Here.
That simply happens. So that's market concentration was one of the major unanticipated, at least for some of the people, was unanticipated. I think it was a highly anticipatory, but it was not anticipated by the policy designers at the time.
So to clarify, if you as an individual don't pay your premium, do you lose access to your healthcare? I mean, just to go back to the beginning of the question.
It illustrates the administrative complexity of imposing a mandate. Imposed mandates. We have mandate to wear a safety belt. We don't have a mandate to take the vaccine for the virus, but we would like to have that. Actually, implicitly, there's law that allow public health authorities to impose such a mandate. We're shying away from that. But even mandates everywhere are complicated, hard to impose, and highly discriminatory. I mean, we have had since the beginning between 2-3%, a bit less, a bit more, now it's between 1% and 2% people who are delinquent in payments. The non-insured it took about 10 years to trace the non-insured and finally get them on a plan, but delinquency, non-payment of premiums was much harder to fight. It's still 1% of the population, between 1% and 2%. Now, that number is trivial compared to what we have here, but politically it's a big thing. Having 200,000 people in Holland or plus without insurance is something we don't like. It's embarrassing. And then the government has tried all sorts of different things. First, they said we're going to triple the premiums with big fines, and you have to. And that, of course, someone who is unemployed or whatever is not going to pay that either. If the €100 is already too much. Second, predictably, who were the uninsured? Young immigrants, welfare recipients, single parents, I mean, vulnerable groups that whatever you do will not all of a sudden behave financially properly and fork over 100 plus euro per month. That's very hard to make them do that. So it was extraordinarily complicated to chase people and make them pay. What was also extraordinarily complicated and very expensive was the fact that for that $100 a month, there was a very complicated scheme of subsidies. Low-income families were given money as to afford this $100 or €100 per month. But in order to establish who was eligible or to establish the amount of that subsidy, the tax department had to hire almost 2,000 people to establish those two qualifications and settle the amount per month. I remember for a couple of years, my brother was a welfare recipient before he retired, and he was getting those subsidies every month, and it was $25.75, $31.99. I mean, it was crazy every single month, and he was very precise. Every single month, he would write a letter to the tax department, excuse me, you made an error. And he was always right. So there was a hilarious stream of letters illustrating that it's very difficult to do. And the idea that you're having letters going back and forth over an amount of $10, you can imagine that it's too crazy to be true. And that illustrates the form of subsidies for premium subsidies.
Yeah, and the complication of it as well. And I just think on like a fundamental, guarantee level, just if we want to talk about the ACA as a form of social insurance, which I personally think is a little bit of a stretch, but to give you an example of what happens in the United States when someone doesn't pay their subsidy. We have an activist, Scott Denoyer. His son was on a Medicaid plan that was administered by private insurance because, of course, there's so much of that. And he missed one $20 payment of his premium to his insurer. And the insurer cut off his insurance for a month and a half. And during that month and a half, he needed a refill of an antipsychotic medication he was taking. That medication was hundreds of dollars and he couldn't afford it out of pocket and they wouldn't cover it. And so he was not able to take that medication and he ended up killing himself. I feel like that is the kind of thing that a Dutch system would never allow.
You reach a very good point here too. In Western Europe, but actually also in Europe, there is, you can say that the dominant public orientation, the value orientation of the very largest share of the populations in Europe is oriented to the healthcare as a right, in the sense that everyone should have access to decent healthcare. It doesn't have first class, best, it doesn't have without any, but it has to be access without insurmountable financial barriers, and everybody should have that. Now, how we do that, it varies wildly across Europe. Is the UK model of tax-based financing of the National Health Service versus the continental German Bismarckian Siegfried model. Those two are the two main ones with more independent administration. There's variety there. There's also variety in a mix of public-private ownership of hospitals, but that doesn't matter that much. It matters more what is the mechanism that would address this public concern. We would not accept people who are elderly ladies in the street who don't have access to hospital. So that's so strong that whatever the tinkering of the system in Holland, we didn't really have to be worried about that point, even if you're not insured to get into a hospital. And that means there's an enormous pressure on governments to, if things go wrong, to jump on it immediately and start patching it. And that occurs all the time. That's why it took so long to implement a new scheme. That went so awkward, and it's nowadays why politicians in Holland do not want to talk about competition and healthcare choices and regulated competition anymore. They know it's a failure. They don't want to admit it, but publicly it's still sort of consumer choice, consumer-driven healthcare. No one believes that.
Yeah, and I was really surprised to learn from you that some of this is really required by treaties within Europe, and that basically governments, if they want to belong to the European Union and some of these other agreements, have no choice but to provide, to fulfill those really basic moral provisions that you talked about.
Exactly. Yeah, the Council of Europe and the ILO, these are really, you're right, these are moral requirements. We as decent states, as nations, we feel that in the European community, that these are prerequisites for a functioning society, not just capitalist societies. Social insurance has nothing to do with socialism. So that's why I'm riled up about that confusion, because social insurance, and if I may add a few words about the origins, came out of the late 19th century, the German politics, where Bismarck, Otto von Bismarck, the chancellor then, had first unified Germany and then looked and saw there's all this rising labor unrest after the Industrial Revolution that drove people to the cities with the dismal urban living conditions, working conditions. And as a preemptive strike, basically, Bismarck figured, and it was very smart, he figured out the notion of social insurance in case of illness and disability and old age, all those elements. And that's also, he was not a tree-hugging, bleeding heart socialist at all. He was a conservative politician, but it was a mix of serious concern, moral concern, but also self-interest. If you want to shore up capitalism, you want to make it work better, make sure people don't lose their house or their car insurance or whatever they didn't have at that time, but because of illness, and make sure people can live a decent life. So that, and then he developed in healthcare, secondly, that's a very important thing. He built on the existing social insurance model, the precursor of the private insurance, by the way, but that insurance model in Germany had already traces that were over 1,000-year-old as the original form of income protection schemes. The medieval guilds, for example, had bricklayers, the bakers, the whatever you have, the carpenters. They all, if you wanted to be a bricklayer, a baker, or carpenter, you had to be a member of your guilds. They would give you an education, a training, a qualification, and then if you wanted to settle, you had to be a member. You had to pay your dues. In exchange, you got this income protection in case of illness or death of the breadwinner. The family was supported. That was a mutual scheme. All the bakers in the region had to be a member. And that model that carried over through the centuries. 19th century, you have the friendly societies in Germany, the farmers associations, the farmers cooperatives did the same. It was all built on mutual interest. They were a pool of risk by themselves. And Bismarck made the additional step to make membership mandatory of those sick funds, but he left the administration in the hand of the existing funds. That caused that model, that the independent sick funds were insurance agencies on behalf of their members, but by mandating membership, they became bigger and their financial base was more solid, so they could survive better. None of that has to do anything with socialism.
No, yeah, exactly. And American capitalism has evolved so differently, and why that's the case is probably a different podcast altogether. But I had one other question about Dutch insurance companies, Dutch insurers, and this is a little more of a wonky question. Do Dutch insurers bear risk in that, like, let's say the members they cover end up being far more expensive than anticipated? Do those Dutch insurers lose all the money?
If you have such a highly concentrated market, my prediction, I've written articles about this stuff. My prediction is that we will end up sooner or later by relabeling it social health insurance, because we have basically 4 conglomerates. And that's such an idiotic, covering 90% of the market. That's such an idiotic oligopoly that you might as well tell them, as of tomorrow, you're not longer risk-bearing, you're part of the social health insurance system, you will be administrative body, period. You do the contracts, but we settle what it is you have to contract about. But we're heading into that direction. So they formally are risk-bearing. However, given their market positions, they can increase premiums if they want to, and they have a very strong position in bargaining with government over this income stream out of the income-related contributions. And tax subsidies, for example, there's tax subsidies for insured under 18 years old. They're paid out of general taxation. There is tax subsidy for a whole slew of things. So that's if you unravel how it works, both at the side of the health insurance, but also at the provision of care, there is a lot of non-private elements.
Right.
And maybe
Right.
that's true for all systems in the world. There is no system that's apart from North Korea and Cuba again, perhaps, no system in the world that's really 100% private or 100% public. Doesn't exist.
Yeah. I mean, maybe you can tell me if this characterization of the Dutch health insurance system is correct. But the way that I understand that it works, and this is in contrast to the American system, where you have private insurers, which don't actually have any kind of equalization fund across insurers. They're just completely self-sustained, taking on all the risk and also taking on all the profit. So the Dutch insurance, a large part of it is funded by progressive, or you could say at least non-regressive income taxes, and those go into a fund which equalizes across all the insurers to make sure that if this fund has a higher burden of high risk enrollees or something, that fund will get more money, and that kind of thing. And so ultimately it's sort of the government which manages the risk for the insurance companies. Is that more or less correct?
Yes, that's right. Yeah, that doesn't sound like a real private market to you. Now, I think your description of American insurers who take on all the risk is a little bit exaggerated. They would rather not have you or me if we have a horrible disease or pre-existing condition. So if they can, they will do everything to keep those insured out.
Right.
Good point.
They're not legally allowed to not accept certain patients, but we all know they try to find ways.
Apart from sorry to interrupt you, but apart from that mechanism, that risk equalization between insurers, there's an additional mechanisms, tax subsidies, to compensate insurers for very, very, very high expenditure patients. People with chronic diseases that are, hundreds of thousands of dollars per year. So that's already taken out of the pool. So sort of double pooling in that sense.
Right. That's been proposed here sometimes. They call it reinsurance here. I remember John Kerry ran on reinsurance when he was running for president, which is the least sexy phrase, and it's hard to most people to understand, but it was a political issue here for a while.
And I'll stick with Medicare for all.
All of those mechanisms, they with good intentions, and so if you think about how it would work in practice, the first thing you'd say, oh, that's an invitation for gaming. I can dump all my high-risk patients. I'm ramping up their diagnosis. I pay doctors a little bit extra for getting a certain share of high. You don't need 100%, but you need a 2 or 3% margin over your competitors. So if you can relabel the diagnosis of 2% of your most elderly, frail population, bingo, you're making a lot of money. And all those things are very hard to avoid or to even trace.
So many of the things that we associate with, I think when people hear this phrase, the Netherlands has a private system, we think of a private market. And as you had just said, a lot of the way it works does not really resemble what we think of as a free market, right? I've written about it, that there, in the end, if you say what came out of the new insurance law of 2006, we found a couple of things that are so striking, that are really sort of worth mentioning, perhaps. I mean, the first is people are not really that interesting to shop around for a new insurance. After the first year, that interest will drop dramatically. Moreover, the only people who are shopping around are not our grandmas who need healthcare most. Actually, it's the children who are just interested in cheap premiums, not in good quality healthcare. So the people who really need healthcare most, and in the original conception of a consumer-driven care, that they should be the one who were driving insurers to make sure grandma gets good healthcare. They are the least mobile. So it was highly predictable. So people
I feel like that also compromises the solidarity of the system. If you allow people to.
If there's all the options the openings you give for risk selection, people will embrace that. And if you're an insurer, you know exactly that the 5% movers, these are the good risk you are trying to lure with free membership of a health club, say. That's very attractive for young and healthy people. The grandmas don't go to do that. And then I wrote down a couple of those elements. What was the effects? Well, the cost control. We thought competition, as in real markets, should help. Well, actually, before in the early 90s, Holland and Switzerland both, where they went a similar direction. They took us on a similar model, but there's some differences. But they both were at the very low end of spenders in healthcare. The share of population about 8%. They were maybe you see the frugal Calvinistic culture. I don't know exactly, but there was a pretty good score in the industrialized world. 10 years later, in both cases, we went up, and at some point, Holland became, after the United States of America, the second most expensive country in the world. So, cost control, not quite.
You think this is related to the increased competition that was allowed, or?
I don't know, or the increased non-competition maybe, or the complexity, or the administrative complexity. Because I mean, there were a couple of things, and because of the new model, did away with some of the intermediary administrative models. Some groups were able to greatly increase their incomes. For example, Dutch general practitioners are now the highest paid in the world. They get a lot of money because everything was paid for all of a sudden, and then they were dragging old ladies from the street to give them a flu shot, and they would get $50 for that. I mean, to summarize what happened with all the behavior, but you could see there was the profit motive was creeping in the whole system everywhere. So cost control out of the window. Consumers didn't like it. Consumers have very low public trust in insurers. But health sick funds were very popular. People were member of our sick funds, but now they have an insurance, they don't care. So they don't trust insurers. The payments, the delinquency the problem that hasn't been solved, and it became so visible. It's not a big problem at all. I mean, if you only have give me a country where you only have 1%, apart from Scandinavia, of course, 1% of non-insured. And then there's another one, the case-based payments. We tried to introduce that. It was at the same time, and that became a dismal failure because Holland didn't want to copy the payment models of the United States or Australia that were already in place, but we wanted to develop our own thing. And that meant that the government delegated the development of DRGs, the diagnosis-based tariffs, delegated that development to individual hospitals. So after a couple of years and hundreds of thousands of dollars, if not millions of dollars, subsidies for private consultancy companies, that resulted in 40,000 DRGs. Now, just imagine you're a hospital administrator and you say, oh, 40,000 DRGs, how the hell are you going to administer that? It was a big disaster. And then they tinkered, and then one day, all of a sudden, the health ministry said, oh, yeah, well, we decided we're going to cut it down, that number from 40,000 to 4,000. Still, 4,000 is a lot of DRGs. I mean, 90% of all the costs are, you could cover that with about less than 100 DRGs, but for 4,000. And now there was an old system before DRGs, then the 40,000 DRGs, and the 4,000 DRGs. So it drove hospital administrators crazy. So that was another one. Still hasn't been solved yet. So we've been, and if that drawn out process of implementation and thinking didn't make the whole model very popular also because it was a bit of a game with changing goalposts. The main purposes changed over time. The goal of consumer choice and satisfaction, good quality, shifted to cost control, and then less government intervention, more to the market. The government would pull back, the market would do the job. And then the latest one was, it was the unfair difference between the public and private market that existed before. That was a bit cumbersome, but it wasn't so unfair because basically 100% of the population was covered. So in any case, that also what it was that reform wasn't clear anymore. And moreover, the last one, the current coalition doesn't mention the word competition or consumer choice anymore. They talk about regional collaboration, go back to the 1970s. So people realize it wasn't such a big success. And it's hard to admit failure if you are a politician.
Yeah. And this kind of brings me to my next question. You know, we're 15 years after this major reform kind of combined the social insurance and the private insurance sectors. And we've seen that it's really not like panning out as maybe they had hoped. Are there any proposals currently in the legislature to change how the system works? Or what is the political discussion around the health insurance system today?
I think it's dead. It's dead and buried, but it's a little bit like a zombie. It will come back because I guess that if we we have always coalition governments, and then it's center politic with right-wing parties or the left-wing party. I mean, it's always for the last 100 years. And that also, that endless turnover in coalition governments has created a large degree of stability, interestingly enough. No one is going way out of of line, because they know 4 years later they may be kicked out and the other party will then. So it looks chaotic, but it is sort of pretty stable politically speaking, apart from one of those little blips of extreme right-wing parties. But no one wants to get burned again. It's like Clinton. You don't want to do Clinton all over. So no one wants to look at the Clinton proposals that basically I thought were proposing German sick funds. If I read this whole 1,400 pages of Clinton, that's interesting. That's just German sick funds of 19th century, but no one wanted to do that. So I don't think there's currently very much taste for restarting debate, but I know, of course, people are looking, informed people are looking at it. It's nonsensical that we are one of the healthiest people in the world, although we are following our US population in obesity and that problem, but we are very healthy. Why do we spend so much? And if you think that, what would be more effective as cost control mechanism? And sadly, all the evidence shows, whether the Dutch evidence in the last 50 years or other countries, cost control without pretty heavy government control is not possible. And if you don't have cost control, you really cannot really propose another model for the whole population. So I think cost control is a really essential one, but you need people who are having, big whip to whip up people to behave properly and to control that. That's complicated, it's administratively complicated, but you do need it. You need, for example, some way of assessing capacities. How do you do that without a government? You don't do that. Not the way you would like to have capacity for the good quality nursing home care, for example. We have left that in the US to the private market. In Holland, it was part of the public system for 50 years. So that's another illustration that market can bring us cars and bicycles and a lot of fun stuff and expensive computers. But the issue of how to allocate the pricing part of healthcare, I don't think that you can privatize. The provision, you can have a mix of public and private actors, but I think the financing, I don't see any example in the world where private health insurance ever was a majority, a major financing source.
Yeah, and that kind of, I feel like you've almost answered the question I was just about to ask you, which is, what role does government have to play in order to achieve a universal, equitable, but also affordable healthcare system? Yeah. And I think kind of one of the themes of what you've been talking about in, well, both the US, but also the Netherlands example is, we may think from our, economics 101 that we learned in high school, that if you add a profit motive to provide a service or a good, that somehow they'll, try to do it more cheaply and gain customers, and that will somehow create efficiency. And yet the opposite seems to happen in healthcare, right? You actually end up with complexity, which drives up costs, and the profit motive kind of backfires on us.
Yeah, no, I agree with that. Is it nicer? Is it better? Is it cheaper for grandma? That should be our core question in healthcare, wherever.
I like that phrasing, actually.
I don't like when you say equitable has. I think it's reasonable. Is it fair? Is it decent? These are elements that I think are much more important. I don't care so much if you pay a little bit more or less than I do. I don't think that's not the essence. The essence is how do we safeguard for the people who need it most access to healthcare?
Right.
So I think our final question, unless Ben, you have anything else, just to return to the discussion of whether or not like a Dutch system is a model for the US, and I think that a reason for a lot of people who say like, well, we can't move to a Medicare for all system because it's not politically feasible, maybe are missing, all of the steps that we would need to take to get to even like a Dutch system, and really assessing whether those are even politically feasible. So for example, the Dutch system, we would have to institute a payroll tax, which would require people to start paying proportionally instead of a flat premium, which, really wouldn't benefit people who are paying, who have very high salaries, and would really benefit people who have low salaries. We would have to like make payouts to shareholders illegal. And we would have to mandate all the benefits. And we wouldn't be allowed, in the United States, self-insurers, they can choose to leave out, they don't actually have to abide by the ACA rules. And that's actually a huge portion of people who are insured today in the United States are insured. Yeah, about half are insured.
Employment-based,
of employment-based are exempt from ACA standards. And so, and maybe like, for example, if, somebody doesn't pay, like Danny Denoyer's son didn't pay 1 month his premium, they would probably have to make some adjustments for like, can you just drop his coverage and drop everything he needs to survive? And these are, a lot of these things are just, I think, as politically difficult to pass as, a Medicare for all system. So I guess the question is, is the Dutch system really a model for the US? Can we get to universal health care through
maybe I feel we have to reframe that question a bit in saying, is the Dutch experience in the last 40, 50 years, is that relevant for the US? And I would think it is, certainly, because all the elements, we have combined all the blocks a little differently, but we share completely the elements. A majority of Americans want to have healthcare for all. It's hard. We have political barriers that are different from the Dutch barriers, but it won't happen so easily. But the elements of what is the role of employers? Historically, in the 1950s and 60s, we didn't have the problems we had today that developed later on. So maybe we have to sit down with employers and say, well, we have a shared interest of controlling costs and having decent care for your employees. And then I remember Lee Iacocca, I remember that he was one of the first ones in the late 80s who stood up as a major employer, said, we need healthcare for all as an employer. So it's not as if we have to sort of think, how could you involve employers in continuing to provide healthcare in a way that's better for everybody? Cheaper for everybody, better for everybody. There's lots of things you could do about that. If we were able, because ending private group insurance through employers has the problem that you don't have an alternative for 150 million people all of a sudden. I don't see that. So maybe we should short up and transform that gradually, and meanwhile work at seeing what is it we can do with Medicare and Medicaid. Why don't we make them more similar? Why don't we define the entitlements in exactly the same way so we can reduce administrative costs as an example? There are lots of things we can learn internally in the US if we take those 5 elements of the US healthcare system, and then also look, how did the Dutch or how did the Danish or how did they solve that particular issue? And luckily, even if we don't seem to be very interested in the rest of the world by now, but there are all those international organizations and networks of academics, and they meet each other and they talk to each other. There is a lot of information, but like you are doing now, it's good to open a window and look at the experience. Not so much because we want to translate or transform a complete model. That happens rarely in history, hardly ever. So that's really a warning, more say, we want to head in that direction, but we have to do it in a nimble way, and not fall for ideas that seem good on paper, like the Ellen Enthoven's regulated competition, managed competition,
right?
Sort of oxymoron that's been alluring, that's been traveling around the world after people in the US and the UK didn't want it, and then they tried to sell it elsewhere. But anyway, so we have to be careful in how we get there.
Yeah, and this takes me back to at the very beginning when you were talking about your experience in government, just how large the players are and how powerful they can become in the healthcare system once you have these really powerful hospital associations, insurance associations, and so on. And I feel after my 15, 16 years working in the Medicare for All movement, I've come to see it politically as kind of the cost is kind of the most difficult political part. That I see Medicare for All kind of as a major cost control proposal. And you're basically talking about cutting funding to some chunk of these players, right? I mean, obviously there's going to be winners and losers, but the losers will fight it to the death. And that's true whether it's Medicare for All or some other form of effective cost control in the healthcare system. So that's probably something that we can all learn from, across countries. But there does have to be, and one of the, I think the reasons it's been so hard in the United States is there has not been a significant, aside from Lee Iacocca, who you mentioned, the steel magnate, car manufacturing magnate, we have not had a strong business voice for universal healthcare, which is strange. You'd expect that we would have seen it outside of the healthcare system. Yeah. But I do think we're going to have to overcome those political barriers if we ever want this to be a functioning healthcare system that we can afford and that is moral and covers everyone. So.
Well, the tragedy is it's not a matter of affordability because we're so filthy rich that we can afford a lot of squandering money. Yep. So, and that's really sad. That's ironic because we don't need to. Is. We could eliminate a lot of costs. But I mean, all the hospital mergers, there's no evidence whatsoever that they have helped to reduce costs. So the efficiency of that, there's no real efficiency gain. So why do we allow all those mergers to become regional monopolies?
Yeah, and you mentioned this managed competition concept, which has come and gone. I don't even know if people hear this phrase anymore, but I do think occasionally people think that they can think their way out of this dilemma of it's politically hard to do cost control, and they're like, well, we'll just come up with something really creative that is, politically palatable, but also controls costs, and it's not. And
it doesn't tell you what it is exactly what you're trying to do.
Right, exactly.
I think the end result is just that there are no shortcuts, but taking on these interests. So,
bring them in. Well, taking on then you are taking on the little David role. I think you need to how can you create a sort of a forum for discussion where you are equal partners? Employers are not going to go away. The need of having insurance for employees doesn't go away one way or another. So whatever it is, they have to be part of that debate.
Yeah, I mean, of course, Medicare for All is my sort of is what I advocate for. But if I had to, if I got the choice, I would easily take a corporatist approach to it as well, if that meant escaping what we have right now in the United States. So
would be better.
Yeah.
Maybe we can join all these EU treaties, and then we'll be required to.
If we could be. Exactly.
Yes.
Well, thank you so much for joining us.
Thank you so much.
We only talked with you about the Netherlands, but we know you have a wealth of experience also about other international comparative about health policy. So maybe we can pick your brain again in the future.
Yeah. Even Rachel Maddow is promoting her own book, so maybe you will allow me to say something that I did with a couple of colleagues. We did write a book this year, came out this year, about the health reform efforts and outcomes in 12 small nations across the world, ranging from Singapore to New Zealand to African countries in Ghana and in Tanzania and Chile and Ecuador. So we had a whole range of countries across the world, East Africa, European included. And what I found interesting writing the book is the diversity of all the arrangements, but the similarity of both policy ambitions, policy goals, but also the political type of problems. So at the level of how you implement it, there's a lot we can learn from each other.
Yeah. And what's the name of the book?
So interesting.
I would love to read it.
I'll show you. You do this, you can hold it like that.
Yes, health reforms across the world.
Health reforms. Anyway, we'll include a link in our podcast notes for it.
Yes, so people can find it.
So if our listeners want to find it, then just go to the podcast notes and we'll have a link there.
All right. Thank you again.